Oh, good morning. I'm Paul Ginsberg and want to welcome you to today's event, Protecting Patients from Surprise Medical Bills. The event is hosted by the Schaeffer Initiative for Innovation in Health Policy, which is a collaborative effort between the USC Schaeffer Center at the University of Southern California and the Brookings Institution. And for those either in person or joining us on the webcast, I invite you to join the discussion and pose questions to panelists using hashtag #SurpriseBills on Twitter. I have the pleasure of introducing Leonard Schaeffer, who's the reason why we're all here today. Leonard Schaeffer was the founding chairman and CEO of WellPoint, now called Anthem. He is currently the Judge Robert McClay Whitney Chair and Professor at USC. In 1986, Schaeffer was recruited as CEO of WellPoint's predecessor company, Blue Cross of California, when it was near bankruptcy. He managed the turnaround of Blue Cross and the IPO creating WellPoint. Under Schaeffer's leadership, the value of the company grew from $11 million to over $49 billion. Before that, Mr. Schaeffer served in the federal government as administrator of the Healthcare Financing Administration, now known as CMS, where he was responsible for the Medicare and Medicaid programs. In 2009, Mr. Schaeffer established the Schaeffer Center for Health Policy and Economics at USC, and he serves as the chair of the center's advisory board. He has also endowed academic chairs in health policy and economics at USC and also at Brookings, the University of California, Berkeley, the National Academy of Medicine, and Harvard Medical School. Mr. Schaeffer is a graduate of Princeton University and was the Regents Lecturer at the University of California at Berkeley, a Gilbert Fellow at Princeton, and a Williams Fellow at Rand. Please join me in welcoming Leonard Schaeffer to kick off today's event.
Well, somehow I don't think you all came to hear about my trouble holding a job over the years. We are here because the world of healthcare is changing and continuing to change in surprising ways. The good news is the uninsured rate hit a record low of 9.1% in 2015. And that means that it's increasingly important that Americans understand and effectively use their insurance coverage. Unfortunately, there are times when an insured individual receives care from an out-of-network provider that they did not choose, and then receives a significant surprise medical bill for those services in an amount that can be overwhelming. Nearly 1/3 of insured adults who have trouble paying medical bills report that the problem of medical debt is the result of an out-of-network bill. And nearly 70% of those who had trouble paying an out-of-network bill were unaware that the provider's network status at the time services were rendered. In addition, as healthcare plans move to high deductible and narrow network products, especially those that are offered on the exchanges, the number of people impacted by this issue is going to increase. Now, some states have taken action to limit the added cost of surprise medical bills. Most recently in California, lawmakers capped how much providers can charge for these surprise out-of-network costs. However, as you're going to hear from the speakers today, state action to date doesn't really address the problem for the majority of working-age adults who get coverage through self-funded employers. Today's event will look at the scope of surprise medical billing, policy reforms to address this problem, and will lay out some future action that's required. That completes my paid political announcement. And so I'm going to begin our conference by welcoming Mark Hall. He is the lead author of today's policy paper. He is the Fred D. and Elizabeth L. Turnage Professor of Law and Public Health at Wake Forest University and a newly minted non-resident senior fellow here at Brookings. He's the author-editor of 20 books, including Making Medical Spending Decisions and Healthcare Law and Ethics, heavy-duty tomes. He brings an expert voice to the discussion here today, having published numerous papers on medical billing and consumer consent. Please join me in welcoming Mark Hall to present the paper, Solving Surprise Medical Bills.
Good morning, and it's a real pleasure and honor to be here to present this paper, which is very much a collaborative effort. I was thrilled to take the lead in sort of doing the research and pulling the draft together, but the other authors had really an instrumental role in this, and it's I think, the most enjoyable and productive collaborative project I've ever worked on. So I also want to thank Paul, Steve Lieberman, who's here, Lauren Adler, and Caitlin Bratt and Maggie Darling, who all have affiliations to Brookings, who helped me with this. So let's start with sort of a basic conceptual definition. Surprise billing, I think, could be characterized as any out-of-pocket billing, out-of-network billing, where the patient lacked what we could call a fair opportunity to seek care in that network. And what would be an absence of fair opportunity? Well, obviously, number one is if the network's simply inadequate. Maybe the patient knows that they're going out of network, but they have no choice. That's an aspect of the problem that we're not addressing. Others are working on network adequacy and what the remedies should be. The Schaeffer Center might take that up in its next project, but we're really looking more at situations where there's an adequate network, but the patient still ends up out of network for reasons that are outside their control. The most obvious would be emergency care, where you simply go to the nearest hospital, and there you really have no control over the situation. I mean, you can imagine telling the ambulance to take you to whatever hospital, but that's not realistic. Oftentimes, even the ambulance might be out of network because whoever 911 sends over. And even if you go to an emergency hospital in network, you have no control over whether the providers who come to your aid, who are on call or what have you, are in network. And so that's a classic situation. And typically it's the one that's first addressed by lawmakers. But beyond the emergency setting, we have other sort of physicians that are facility-based that are oftentimes non-participating, even though the facility it is participating. So as you all know, doctors typically are independent from hospitals and make their own decisions about who to contract with. And so we have many situations of hospital in network but surgeon isn't, or surgeons in network but assistant surgeon isn't, or surgeons are but anesthesia isn't, or anesthesia is but pathology isn't, and all down the line. And again, those are situations where patients have essentially no notice, and even if they did, very little at all that they could do about it. And beyond that, in outpatient settings, there are other situations to be concerned about. Routine outpatient care, referring things to labs that may or may not be in network, or sending patients to see consulting physicians and not realizing that, or diagnostic testing. So really up and down sort of the chain of treatment, it's quite possible that these arrangements could arise. And as Len said, it's appearing that they're arising more frequently than before. The paper has an example. Does this? Yes. That this is just a prototypical. So there's various sort of extreme examples that the press would tend to focus on to show the magnitude of the problem, where the patient's left owing a bill for hundreds of thousands of dollars. And of course, sometimes the patient's left owing a bill for only a few $100s. So we picked a scenario that was sort of in the middle, where you could imagine being not uncommon, a procedure. Is this showing up in any way? Can't see it. You? Well, is the pointer not working? Okay, let me see if I can do it this way. Is this arrow showing? No. Anyway, top row, let's say a procedure that's billed out at a charge matches rate of $10,000, where the plan contracts to cover it for $4,000. Now you might say that's a big difference, but as you know, a two and a half-fold difference between charge master and contracted rate is not at all unusual. So if you then look at in-network care, followed all the way to the bottom, no problem. If you've met the deductible, which here I put up as modest, but whatever it is, if you met it, you only pay your copay, or you pay your deductible and your copay. But if it's a strict HMO, classic HMO, you have no coverage whatsoever out of network, and so that $10,000 flows all the way to the bottom line. There's no contribution from the plan. As we know, these HMOs or EPOs are becoming more common, particularly on the marketplace exchanges, where people are least able, because they're the ones qualifying for subsidy, the least able to pay for a large bill out of network. In a more classic PPO situation, you would have some coverage, but oftentimes the plan will have its own review of whether that $10,000 is usual, customary, and reasonable, and perhaps it would decide only $6,000 is sort of the market rate for that. So the patient would still owe the provider the remaining $4,000. Plus, even with respect to the $6,000, there's oftentimes a financial penalty imposed by the plan for going out of network, which would be a co-insurance rate, say 30%, and perhaps a higher deductible. So depending on where you are with your deductible and these other assumptions, even though there's out-of-network coverage, you could well end up owing anywhere from over half to three-quarters of the full charge. And so these are very typical scenarios, and as you heard, they're happening more commonly. And so in terms of the extent of the problem, what really struck me as I got into it is that there really is no disagreement among stakeholders and among the public policy community that this is a problem that needs to be addressed. I see sort of broad agreement to that basic principle from all the main stakeholders, all the specialty groups, all the provider groups, all the plans. Not every single one of them, but they're major representative organizations. I didn't see anyone saying, oh, this is a minor problem that the market should fix or regulators should leave alone. I also see broad bipartisan agreement in that the states that have done something on this include both blue states and red states and purple states. We heard about California, but also Texas was an early actor, Colorado, Florida, New York, some others. And so there seems to be across the political spectrum interest in dealing with this, and the paper points to various pieces of pending legislation, that probably won't go anywhere in this Congress, but shows a willingness among some congressional leaders to pursue this, both from the left and the right. So rather than spending more time, well, let me just sort of one other example of how extensive it is. Len gave you some figures about how many people are affected, but this is just one example from Texas, but it's very revealing. It was simply a survey of the major carriers in Texas, Blue Cross, Humana, United, what percentage of their hospitals had zero specialists in network for key specialties. And for emergency physicians, anywhere from a fifth to over half of the hospitals of these leading networks, leading carriers, had no emergency physicians on staff. For anesthesiology, good coverage for one, but at least that most of all their hospitals had at least one anesthesiologist. But the other two carriers, anywhere from 14 to 38% of the hospitals had zero anesthesiologists, radiologists, pathologists, neonatologists. So this is a large state with the largest carriers, and so this is more than anecdotal and represents the extent of the potential problem. So understanding that there's wide recognition of the problem, this paper really focuses on what are the solutions. And other papers have done a great job mapping out the extent of the problem and mapping out what is it that states are doing. This paper sort of looks at the gaps and says what else needs to be done, or which of these approaches by the states and potentially by the feds appears to hold the most promise. So first are a series of ideas that might be helpful but are incomplete. And so the first response is, well, all right, let's hold the plan responsible in some way. And we tend to do this with emergency care. So EMTALA and what have you require providers to cover emergency care, so there's no choice. So the ACA has a rule that's replicated in a number of states that patients who seek care, emergency care out of network, have to be held harmless in the sense that the plan may not charge them any more than the standard co-payments. And that's a good starting point. It goes as far as to address sort of the immediate impact on the patient and the plan's responsibility, but it doesn't address the extent to which providers can balance bills. So the ACA says that the plans must pay the providers the greater of usual rates or Medicare times 125 or contracted rates, I believe. So the plan says that the ACA says that the plan must pay the provider a certain amount, but that certain amount still might not be the full bill. So providers are still allowed to balance bill under the ACA with respect to emergency care. Another approach is to try to diminish the extent of the problem in non-emergency situations where patients might be better able to choose providers based on network status. What about giving them better notice? So better directories of who their providers are so they can look them up. That's certainly seriously needed. But where does that lead us in terms of patients who still seek care out of network? How do we know they really did that sort of voluntarily and with good information versus in a more surprise or unfair scenario where they didn't have much choice? Well, you would need something along the lines of what they happen to call in Australia informed financial consent, a nice little sabbatical junket I had. I discovered they use this idea every day. I said, well, that's an interesting little phrase. I'll build on it. So what would it mean to really give true consent to being sent out of network or using an anesthesiologist? Well, you'd have to think about what the notice says, that this is what's happening, and not just that this is what's happening, but this is how much it's going to cost you. And these elements are built into the California recent law, by the way, as well as a couple of others. You'd have to think about the timing of the notice, that it's being given sufficiently in advance, and I think California says 24 hours or something to that effect, so that patients can make other arrangements. And you'd have to think about this being done in a non-coercive way. So even with 24 hours in advance, if you've already sort of made your major decisions about which surgeon and which hospital and what procedure, and you're getting down to the wire, and suddenly somebody says, oh, here's a piece of paper that says you're going to have to pay your anesthesiologist $1,500. How realistic is it that you're going to sort of call everything off and say, I got to go find myself another doctor in the hospital because this hospital doesn't have anybody in network? I think there's serious concerns there about enforcing the informed financial consent in ways that are non-coercive. And so to be most effective, the notice would also have to say, we're proposing a non-network provider, but if you don't like that, here's how you make an alternative choice and really make it truly feasible. That being said, certainly we want to preserve the right of patients to seek out their preferred doctors and not do anything that penalizes the doctors for, working with patients who truly desire their services despite being adequately informed. Another idea that's in discussion that we think is useful, but it only goes so far, is to think to what extent hospitals have some leverage over their hospital-based specialists. So if the hospital is in network, to most people's logic, shouldn't that mean that the hospital-based specialists are, but as we know, they're independent. But hospitals could exert a certain amount of influence through their contracting, so if they have a selective contract for emergency care or radiology or what have you, couldn't that contract say, well, to be part of this selective contract, you have to at least belong to our major networks, maybe not every single one. Or even further thought, credentialing to be part of the medical staff. We want to present ourselves as a single integrated, ACO type, whatever, so we can contract with plans and providers. We can't do that unless we're all sort of on board here. And so if you want to be part of the institution, we need to all be willing to contract together. So there's a lot of attraction to that, but there's also a lot of realistic limitations. In many places, hospitals lack the leverage to do this or to get this leverage, because there's enough competition. Physicians can go elsewhere. Physicians have consolidated and simply are going to push back. Or if they're going to get that leverage, they'll have to pay for it. And so we read about how hospitals already have to pay specialists to do on-call coverage because many of those patients are uninsured, and that can get to be expensive. So if we did that more across the board, that could just get is an expense that could get built into the hospital rates that get passed on to the consumer. So it doesn't constitute a full solution, although it's something well worth thinking more about. But the point so far is that there isn't a magic bullet solution, that we can't simply say, health plan, fix it, provider may not balance bill, just simply get the patient better informed. It's a much more complex problem that requires a multifaceted response. So in my remaining time, which I don't see a clock, but somebody will wave at me if I'm going on too long, we want to think more comprehensively. So how to fix the problem in as sort of a comprehensive way as possible. So I'll start with some few basic principles and then get on to our sort of bullet point suggestions. The first is, the main principle is, the first rule of surprise billing is hold the patient harmless. I mean, the judgment is it's not fair to the patient, and whatever disagreement there is ought to be worked out between the plan and the provider. Let the patient off the hook. So to some extent that does mean ban balance billing once you've decided what the payment rules are between the plan and the provider. So that's a simple, clear kind of edict that we shouldn't lose sight of in crafting these things. The next thing is, once we hold the patient harmless, there is a genuine dispute between the plan and the provider, and we have to figure out what is the fair and efficient way to resolve that disagreement over what should be paid between two, by definition, non-contracting parties. They could go to court and work it out, but that approach is expensive and clumsy, time-consuming, and courts really lack guidance on what are the governing principles here. These contract terms, there aren't a contract, but sort of the governing concepts that might come out of regulation. Is the network adequate? Is there an obligation to pay reasonable rates? Are too mushy and squishy for courts to really be enthusiastic about getting in and resolving all this. They see it as messing with, an area that ought to be regulated, or we ought to leave the parties alone or something. So it's not as if the courts shouldn't be resorted to, but they are hardly sort of the first and best process on an ongoing basis. The other principle is to, whatever we come up with, think about the potential distortion of market mechanisms. So a rule that says, put the onus on the health plan would mean providers have much less incentive to negotiate because they're going to get paid anyway, particularly if they're in a specialty that for whom most of their business or much of their business can come from out of network, such as emergency care. But if you say, let's cap what we pay the providers at something close to Medicare, then what incentive do the providers have to negotiate further to join the network? So they'll just, if this is all I'm going to get, I'll take my Medicare times whatever 25% and just sit out of network. And so you want a process that sort of sets boundaries on either side, but still leaves room and incentive for negotiation. And that's a tricky balance to call for, but it's something to be aware of. Finally, the solution needs to be comprehensive in the following ways that existing law fails to do. First, you need to cover all plan types. So a number of states have laws that govern HMOs because if there's no out-of-network coverage, that's the problem's no severe. But we need EPOs, which are indemnity-regulated versions of HMOs, and we also need PPOs covered because as networks get narrower and penalties for going out of network get stronger, the problems are significant there. Most importantly, we need to remember that only half the market in terms of private insurance is state regulated. The other half is not state regulated because it's ERISA preempted self-funded plans. And so it seems silly to construct a thoughtful, comprehensive solution that leaves out half the market. And we have no reason to believe that the incidence of this is any different in large groups than small groups, except possibly differences in the size of the network could mean it's a little less significant. But certainly all the fundamental elements are just the same. And in fact, in self-funded plans, it's possible that the financial consequence could be more severe because self-funded plans have more freedom to limit what they pay out of network. And there are reports that they aren't paying UCR, they're paying just a contracted rate, Medicare plus 60% or some other number, which could leave patients exposed to even more balanced billing. So obviously to get to self-funded plans, we need a federal solution, and also all the major treatment areas, not just emergency, but all facility-based, and some thought about whether you go beyond facilities to outpatient. So here are the specifics, and I believe my final, 2 slides. Federal actions needed, or you're not going to get a comprehensive solution. Starting point is, since the feds already regulate what is an emergency care, EMTALA says you have to treat. Prudent layperson rule says this has to be considered an emergency if it feels like one. And for these situations, the plan has to pay the highest of 3 rates to the provider. So since you go that far, it's only one final, modest step to go ahead and ban balanced billing. So it seems logical that that would be built into federal action. And it would cover all plan types. Then with respect to non-emergency care, states need authority to regulate, or the self-insured plans, which would require a congressional amendment, or you need a federal fallback for states that don't regulate, following kind of a HIPAA model that first started that idea, a federal standard that states are welcome to emulate, but something or some combination of federal and state regulation. And this gets more complex, but states are authorized to regulate provider payment rates under ERISA. The feds are currently authorized to regulate dispute resolution mechanisms by plans. So there might be a creative way of combining the federal authority over dispute resolution with the state authority over provider rates and create some kind of ERISA hybrid thing that would need some more thought. But these creative minds can work this out. Or just a piece of legislation that says, here's what we're doing. But tricky terrain, but it has to be worked through if you want a comprehensive solution, something other than half the population. Then what does the solution entail? Dispute resolution. We hear a lot about this in terms of New York and Florida and California. Some states use independent review, the same type of process they use to resolve medical necessity disputes. That would be perfectly fine. Other states, and New York has been the leader in this, come up with a really expedited, streamlined resolution process known as baseball style or best offer, meaning the parties come to the table with their best and final offer. Final offer is actually the phrase, best or final. Final should be in there. And then the arbitrator can only pick one or the other of those numbers, can't split the baby. And that's done based on sort of limited presentation. So it's an incentive to settle so that you don't, because it's all or nothing kind of stakes. And it can be set up in a way that's done expeditiously. So there's interesting sort of experimentation going on. This is different than other concepts such as mediation, which is simply trying to achieve settlement, does not produce binding results, or voluntary arbitration, which is binding, but parties don't have to engage into it unless they want to. So you have to be careful in terms of dispute resolution. Is it mandatory? Is it binding? And is it an efficient form of it? So with that said, then we come back to the sort of the, 800-pound gorilla. What do we do with rates? And we simply can't avoid some attempt to benchmark rates, because these dispute resolution mechanisms have to have some standard that governs what is the payment rate. And so right now we just have, UCR, usual, customer, and reasonable. And that could give better definition, but there are other ideas out there that are worth considering. So first of all, to benchmark rates doesn't mean you have to set rates. You could benchmark rates in ways that are presumptive, that say, in the absence of party dispute or in the absence of party agreement, these are presumptively the most that the provider can get paid, or the least that the plan has to pay. So you can have a sort of a floor and a ceiling that's set sort of default payment rates that then can be further challenged if one of the parties feels that the ceiling's too high or the floor is too low, or what have you. So as opposed to saying this is the rate. So both of those can be done, and we see examples in different states. That benchmarking can be done as a percentage or percentile, which are two different concepts to statisticians, of one of three things. You can work off of Medicare, which I understand is controversial, but some people say 200% of Medicare. So just because it's Medicare doesn't mean it needs to be 25% of Medicare, although, you could take this idea of amounts generally billed that's been built into the tax code as the reference point for charging low-income patients by tax-exempt hospitals. So it's a formula for calculating what's the typical amount that the health plan pays and under its commercially negotiated managed care contracts. And you could take that and then add a percentage to that. So you could say 20 or 25% over sort of their standard contracted rate, however phrased. But the concept and the phrasing is already in the IRS law without the add-on amount, but you could add on the amount for others. Or you could designate a certain sort of commonly accepted database, and we often hear about Fair Health, and this is referenced in New York law and Connecticut law as the place where you go to find what is UCR and say, well, UNC, usual and customary, is in their database. Reasonable is the, say, 85th percentile or the 75th percentile or whatever percentile the regulators agree to. So with all that said, I ended up with my Goldilocks analogy, which I used in the paper, which is this, again, is not a silver bullet magic solution. You got approaches that seem too lenient, approaches that seem too aggressive, but in the middle, I think there is this sort of just right mix of solutions. It's a bit of a porridge in the sense that it's not a single ingredient thing. It requires a number of elements working together. But we hope through this paper and this analysis to sort of bracketed out what we think are sort of the most viable ideas moving forward. And we hope that as we engage the stakeholder panel and the public policy panel, that we can get more thoughtful reaction to this. And so with that, I'll sort of conclude my remarks. I'll take sort of more discussion during the stakeholder process. But thank you for your attention, and let me next call up our next moderator. Dana Goldman is a distinguished economist at USC, where he directs the Schaeffer Center for Health Policy and Economics. And let me also call forward the next panel, the stakeholder panel, if you all will presumably take seats here. Is that right, Dana, on the stage?
We'll get mic'd up.
Okay, and get mic'd up. All right, well, thank you very much.